Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Welcome to our first Podinar session with a special guest from England, Dr. Paul Tipton. Welcome to our Podinar session today.
Thank you. Nice to see you.
Nice to see you as well. So what is a Podinar, my friends? We are doing about a half and half podcast format as well as webinar format, so our viewers can get a closer connection with our speakers and their topics and their backgrounds and where they have come from and who, where, and most importantly, why. And today we will be discussing a very, very hot topic that most of you encounter in your clinical practice with an expert in the field, Dr. Tipton. Before we go into getting a little bit to know Dr. Tipton, let's have a quick review of his credentials. He's a highly respected specialist in prosthodontics across the world. Dr. Paul has published over 100 scientific articles in the dental press and is an expert lecturer in this field with Tipton Training Academics in Manchester, London, where he resides, and in Dubai. It's www.tiptontraining.co.uk. After gaining his master's degree in conservative dentistry in 1989, he was awarded a diploma in general dental practice by the Royal College of Surgeons. 4 years later, and received specialty status in prosthodontics in 1999 from the GDC. He is currently a professor of cosmetic dentistry at the City of London Dental School and BPP University and president of the British Academy of Restorative Dentistry, www.bard.uk.com. An ex-professional cricketer with Lancashire County Cricket Club, he's one of the most successful dentists in the UK, and you can visit his personal website at drpaultipton.com, where he has specialty clinics in Manchester and London, tclinic.co.uk, and regularly appears in Dentistry Top 50 UK Dentists poll. Wow, you are everything that is that's British, Dr. Paul Tipton. Very exciting to have you. So, Dr. Tipton, over 100 publications since 1989. 1989.
I'm not that old.
You're certainly not that old. What has been the motivation? What were the core focus on your research and your career?
My motivation, I think, has been to excellence. I suppose that's it, excellence. So I've always striven for excellence since doing my master's degree. I was lucky to come into contact with some excellent teachers and trainers when I was doing my master's degree at the Eastman in London. And I got the bug, I suppose, at that stage for teaching and for just trying to be as good as I could possibly be. So the motivation has been to be as good as I can be.
That's wonderful. We can never reach perfection, but we can get close to it by working with others and bringing that to the forefront. So your research was mostly in cosmetic dentistry, materials.
Mostly restorative dentistry.
Mostly restorative dentistry.
Yep.
So in the last few decades, a lot of things have changed. You've seen a lot of people come and go.
Yes,
what is your
absolutely.
prediction of the future?
Oh, gosh. Who could have predicted where we'd be now? I think a lot of people would have lost a lot of money if they'd be predicting the future. So I've got no crystal ball. I have no idea. This has thrown a complete spanner in the works. So goodness knows where we're going to be in 3 months' time, in 12 months' time. No idea.
So in your time, it was more of a single practice, one-on-one. Have in our country now, in the U.S., it has changed quite a bit to a lot of corporations coming into our industry. Is that happening in Europe as well?
Yeah. Certainly in the UK, about 30%, I think it's 25% maybe, of practices are owned by corporates now. And that is coming in more and more and more. And less and less is it the single-handed practitioner. It's a shame.
It's very shameful, and there are some things done in the U.S. to prevent that expansion, because no matter how you way you put it and how you describe it, at the end of the day, there's a third party that's unlicensed that's interfering with the patient-doctor relationship. That's
Absolutely.
essentially what it boils down to. Because no matter how you structure it, material selection, your staff selection, your hour selection, your the way you want to conduct your business, it all trickles down to what happens chairside. And we have this problem where, under the guise of management, we have a lot of interferences with that now. Very good. So.
Yeah.
So tell us about your hobbies. Cricketer, you had quite a bit of a career.
I was going back many, many years ago. I used to play for England under-19s at cricket. So my passion before dentistry has always been cricket, sport generally, but cricket. Cricket is, I won't say our national game because football's our national game. Cricket's our second national game. The national game during the summertime, during the if you can believe it, when England have some good weather. So that's when we play cricket. Been my passion. I was lucky enough to be good enough at it to be paid to do it. So for several years, I was paid to be a professional for Lancashire County Cricket Club. That was after I'd been playing for England under-19s. And during that time, I also decided that I needed to get myself qualified. So sort of halfway through that time of playing professional cricket, I also went to university and got myself qualified as a dentist.
Wow. And how long have you been a professor for, doctor?
That's 7 years.
7 years. Do you find that the educational side of the profession rewarding?
Very, very much so. I try to still keep my business so that I do roughly 50% clinical work and 50% teaching. It's more and more difficult because I get asked an awful lot more to do the teaching side, but I do try to keep a lid on it, try to keep it so it stays at 50-50 roughly. There'll be times during the week or 1 week where I might do 5-6 days teaching, no clinical work, and then the next week maybe 5 clinical days, and it's up and down. But over a period of a year, it stays at about that 50-50.
50-50, wow. So you're bringing a topic to the table that a lot of us can relate to, which is the worn dentition.
Yeah.
A lot of my colleagues don't have the experience or knowledge about occlusion, and we restore things, and then they fall apart, and then you restore them again, and then it becomes a issue of contention with the patient, and things start trickling down into a negative direction. What would you say to someone that encounters this problem and doesn't necessarily doesn't have the skills and knowledge to properly restore patients to function?
I think that the basic thing, and I don't know what it's like in other countries, I can only speak for the areas that I go into regularly. So I obviously teach a lot in the UK. I teach a lot in the Middle East. We have an academy out in Dubai. So I spend probably 1 week in every 4 to 6 weeks in Dubai or Kuwait or the Middle East somewhere teaching. So I understand what is going on there with the undergraduate teaching and what's going on with the UK undergraduate teaching. And occlusion's just hardly mentioned. And for me, occlusion is the biggest topic in dentistry. If you don't understand occlusion, you know, I'm quite forthright with my views, you can't be a dentist. All you are, if you don't understand occlusion, is basically a tooth filler, because to understand occlusion is to understand the masticatory system. And that's what we should be doing. And that falls through into every different part of dentistry, whether it's prosthodontics, cosmetic work. Your perio is going to fail if the occlusion's wrong. The endo won't settle down if the occlusion's wrong. Your orthodontics won't be stable if the occlusion's wrong. So it all comes down to the undergraduate training. And I feel very, very sorry for so many young dentists now who are qualifying who just do not understand occlusion. And my advice, going back to your question, my advice is to take time out, as now we're being forced to, and go backwards and start to learn occlusion, because that will then benefit everybody. Everybody will be able to go again with then a much deeper knowledge of why things work and why things fail. And the key thing for everything in dentistry, as I'm sure you'll understand and agree with, is predictability. We need to be able to look at the patient or look at a treatment that we're doing and be able to say, this will work predictably. Not it will work in you, but I don't know why it doesn't work in you. Perhaps you've got a strong bite and therefore it doesn't work. That's not predictable. And if you understand occlusion, you can start to get predictability into all of your restorations.
Excellent. I certainly agree with you that occlusion will affect just about every discipline in dentistry. What do you say to someone that goes through a curriculum and, for example, starts, let's say, working with Kois appliances, and the patient continues to break those appliances, and they just get frustrated and go to the final restoration?
I think you need to, I think that you have to have a broader knowledge of occlusion. Not every appliance will work for every patient. And so you've got to be able to have more than one particular option in your locker. And I think that's the lovely thing about dentistry. You know yourself that if you put 10 dentists in the room and see that same patient, there'll be 10 different treatment plans. Okay? Because we all have a different way. At the end of the day, hopefully we'll get the patient treated to what the patient would like to have as an end result. But there's many, many ways of getting there. So I think people need to have a broader idea, not just stick to one appliance only.
That's very smart. And I'm sure you're going to give us a little bit of feedback and some toolboxes to use in our clinical practice. It's funny that you said that, because there's a saying that says a camel is a horse made by a committee. And and I can certainly relate to that. Very good. Dr. Tipton, we are actually very excited. We have had a lot of contacts about this particular webinar. I'd like to hear some input from Europe as well. And with that said, I'm going to go ahead and start switching you over to our presentation so we can get started with this wonderful topic. Dr. Tipton, you have the floor.
Okay, thank you very much indeed. And good, as we said before, good morning, good afternoon, good evening, good night, depends on where you are in the world. Thank you very much, Dr. Shah, for the introduction. I don't need to go through this first slide because it's all been said. And so let's get into the bulk of what I'm going to be talking about today, which is how do we treat wear cases? What different ways have we got? So first of all, let's look at the etiology of wear. And if we look at that etiology, we've got a couple of things happening. A couple of, I'll call them disease processes for the sake of it. We've got somebody who's clenching and grinding their teeth. And we may have somebody who's got erosion at the same time. It may just be erosion, but these are the two major causes of tooth surface loss, and potentially the bruxism can go on to create temporomandibular joint disease. So what is it about bruxism? And I think we have to understand that bruxism is obviously parafunction, non-normal function. And if we look at the studies, to give you an idea, as I go through the presentation, I'll ask you, the listener, as many questions as I can, just to try to focus the mind. So the first question I'm going to ask you is, or ask you to do, is to clench your teeth as hard as you possibly can. So all of you, please go out there and just clench your teeth as hard as you possibly can. Okay, now if we look at the forces involved there, the forces involved are around about 30 to 60 Newton centimeter. That's your maximum biting force. However, what stops you biting harder? So if I say to you now, clench harder, come on, clench harder, clench harder, clench harder. You cannot clench any harder. And the reason being that we have something, thank goodness, called proprioception. And that proprioception is like a little switch. And that proprioception, when it's on, overrides the conscious. So the unconscious proprioception is saying to the conscious self, do not clench any harder, otherwise you'll create some damage, you'll cause damage somewhere. And that damage can be somewhere in the masticatory system. That may be in the joints, in the muscles, the periodontal ligaments, or the teeth themselves. Now, What happens at nighttime? At nighttime, we go to sleep, and that little switch called proprioception is switched off. So now, when we start to clench during parafunction at nighttime, we've got no inhibitory reflex, which says do not bite as hard. And so now it's been shown that we can now start to clench and grind with 300 Newton per centimeter squared. So we're now talking about a 5 to 10 times the force. Now, again, at this stage, time out, just think about that force. Think about your maximum biting force now, and me saying to you, bite harder, and you're not able to bite 5% harder. What does it feel like to think biting 5 times or 10 times as hard? That's our problem with bruxing. Next part is that if we look at again at the studies and how long our teeth are in contact for in a normal waking day. So let's say 16 hours we're awake. A normal waking day, our teeth are in contact, depending on the study you read, anywhere between about 4 and 15 minutes. And those are fleeting contacts. As we're chewing, as we swallow, and we close our teeth together, those are fleeting contacts. When we are clenching and grinding at nighttime, then those forces, 5 to 10 times as hard, can be there for 3 to 4 hours. So instead of 4 to 15, 4 to 12 minutes, 3 to 4 hours. And that led a very, very learned colleague of mine to go and say that one night of bruxing is equivalent to a lifetime of chewing. So that's the problem we've got with bruxism, and it can cause all sorts of problems, as you well know. These are some of the signs and symptoms that we have of wear, temporomandibular joint disease, often caused by bruxing, not always, but often caused by bruxing. Let's look through these. And as we look through these signs and symptoms, guys, please yourself do a mental audit. Dr. Shah said that this is something that's happening to so many people. Patients and dentists obviously are seeing it. A quick mental audit in your own practice, whatever that practice is, mental audit of your adult patients. What percentage of them are suffering from any, not all, any of these signs and symptoms? So they have a history of fractured teeth, fractured restorations, palatal cusps which have fractured off, buccal cusps which have fractured off, vertical fractures down the long axis, so lower molar tooth, completely fractured in half with no restorations there whatsoever. What percentage of your patients have got temporomandibular joint problems? Maybe clicking or crepitus in the joint. Maybe they've got pain around their joint. How many patients, what percentage have got muscular pain, suffering from headaches? Headaches here, headaches behind the eyes, many headaches in the masseters, into the neck. What amount of your patients have got faceting, have got worn teeth? Their teeth are wearing down prematurely, dependent upon what age they obviously are. Abfraction lesions occurring at the neck of the tooth. We know that that's not caused totally by bruxing, but bruxing may well have something to do with it. And what about perio? What percentage of your patients who do not have periodontal disease have still got recession defects and has still got mobility? So add up all of these, and you can only answer for your practice. Commonly when I'm lecturing in the UK, then I ask that question, and most of the dentists I'm lecturing to will say 80 to 90%. Some of the dentists are going to say 100%. Don't believe them, but okay, let's say 80 to 90%. I go throughout the Middle East, and in the Middle East, when I ask that same question, it's more like 60 to 70%. And what I'd like to call this is not wear. I'd like to call this occlusal disease. I'd like to call this occlusal disease because this now puts it into context. And here's the context. If you've seen somebody and they've got periodontal disease, what happens if you don't treat that periodontal disease? Patient might get worse, and what does the patient do? He litigates against you. There's a lawsuit against you because you have neglected the patient, and there's a negligence suit against you. Okay, let's look at caries as well. A patient's coming to you and they're constantly got caries in the mouth. You're doing nothing about it. You've not restored them. The caries lesions are getting worse and worse. Again, that's another lawsuit, and that's negligence. But so many dentists are looking at this amount of wear, and it's getting bigger and bigger, the problem, and they're just sitting there and not doing an awful lot about it. And that is called negligence. So we have to understand that we can't just sit there and say, oh, your teeth are wearing down a little bit. Oh, well, it's just one of those things. We have to start treating it. And we can treat it in one of many ways. But you would never dream of a patient who's got periodontal disease in your practice who needs restorations. You would never dream of doing the restorations without sorting out the periodontal disease first, correct? Likewise, somebody's got caries but needs a lot of multiple restorations, crowns, bridges, or whatever. You would not dream of doing the crowns and bridges and leaving caries lesions around the rest of the mouth. You'll go in and you'll treat the caries, you'll look at the diet, you'll get some fluoride in there, you'll restore the teeth, put some cores in, and then go and do the restorative dentistry, the crown and bridge work. Okay, what happens with occlusal disease? You see these signs and symptoms. These signs and symptoms aren't just there because something's happened. These signs and symptoms are there because the patient's suffering from an occlusal problem. The bruxing and occlusion is causing problems. And I'm just calling that disease for the time being. What should you do? You should go and treat the occlusal disease number 1 and then do the restorations. So let's look at how we start to treat these occlusal disease patients. Number 1, let's just go back one slide. Number 1, we have 3 ways of treating our patients. Number 1 is to stop them bruxing. Okay, how do we do that? Trials have been out there. Hypnotism. You will stop bruxing. You will stop bruxing. Guess what? Doesn't work. Trying to reduce the stress. Okay, what causes bruxing? Most of it is stress. Yes, there could be airway problems, but most of it is stress. And can we stop stress from affecting our patients? Answer is no, we can't. Certainly as dentists, we can't. So we're not going to be able to treat the stress at source very often. So we have to accept that our patients will be stressed and therefore they will be bruxing. So we have 2 options now to try to work with or control the bruxing. Okay, number 1, simple thing, put something between the teeth so that when the patient bruxes, that something acts as a shock absorber and therefore the stress does not go to the teeth, the ligaments, the joints, the muscles. It's a little bit like somebody who's banging their head against a brick wall constantly. You put a pillow, you put some foam against the brick wall. So when he hits his head against the brick wall, he doesn't damage his head anymore. That's basically what the occlusal splint is doing. It is absorbing the stress and stopping any future breakdown of the masticatory system. And we use various types of splint. It's interesting. There are many splints out there. You know, lots of people go and put their names to splints. I use mostly a Michigan splint or a Tanner appliance. Those are full coverage, as you can see on your screen here. This is a full coverage, hard acrylic, fully adjusted splint. So I use a Michigan splint, the upper splint, for a class 1 and class 2 patient. And I use a Tanner appliance, which is this splint only in the lower jaw for a class 3 patient. And what's our problems? Our problems are that 2 things. Number 1, a good splint is expensive. It's expensive, not particularly to make, but to fit. It takes a lot of grinding in the patient's mouth to get it so it's exactly right and doing its job. Therefore, it's an expensive item of work. Number 2, it's removable, so we don't know if our patients are actually using it or not. And we always have the problem. If we're relying on the splint to stop any damage occurring to our beautiful veneers that we've done, our onlays, etc. And we're relying on the splint. Very easy for the patient to say, yes, I've been wearing my splint, doctor. Absolutely. Every single night I'm wearing them. And it was just during the day when I had a chicken sandwich that this broke. And our problem is we have no real way of disproving them. So we use a lot of splints, but we shouldn't have to rely on them totally. Because if we rely on them totally, we cannot be sure our patient is actually going to wear them. So our second option is the splint. And my preference, as I said before, is a fully adjusted, full coverage splint. Now, I know lots of people like Cois appliances, other people like B-splints, some people like anterior jigs, those sorts of things. I don't like anterior splints on their own. Great at treating muscles, not great at treating joints. From my point of view, to treat a joint problem, you also need to have posterior stability. For treating muscles, yes, an anterior splint works very well. I don't like soft splints, bite raising appliances. They don't work at all in my eyes. A very nice study done in the British Dental Journal about 12 months ago by Professor Nairn Wilson looked at all different types of splints and found in his research, his conclusions were that the fully adjusted full upper or lower splint was the only one that would work most of the time, and also when it didn't work would not cause any further damage. And I think that's one of the other problems. We know anecdotally soft splints do work in some people, but in other people they don't work, but they cause damage. Anterior splints work in some people very well, but in other people they can cause damage. That damage that can be caused can be caused by over eruption. So we have to be aware that if we do put something in the mouth, number one, let's make sure that it doesn't do any further damage. And number two, let's hope it does some good for our patients. Our third treatment, and this is obviously where I'm going to be concentrating in this presentation, is actually restoring the patient. And when we restore them, we have to restore them in a different way. Otherwise, if we restore them the way they've been restored previously, it's going to fail again. Remember, Einstein had that lovely quote that the definition of being an idiot is trying the same thing time and time again and expecting a different result. So let's not be idiots. Let's start to use our brain, understand, and let's try and restore them in a different way. So restoration, I'm going to put into two parts. We're going to have restoration with composite, and we're going to have restoration with ceramic. I like to use composite a lot as a trial material. And if my patient can afford it, we will then transition to ceramic. If my patient can't afford it, then we will keep them going in composite for as long as we can. And bear in mind that the composite maybe is lasting in that 5 to 7 year period before it needs to be replaced. So let's give you a couple of examples of the composite first of all. Now, I love these two slides. This is my favorite slides, I think, whenever I lecture anywhere around the world. And this emphasizes so much that if you understand occlusion, occlusion can be so easy. Remember, all we're doing with occlusion is sticking to certain rules and principles and getting the bite right as we go up and down like this, getting the bite right when we go forwards and backwards, and getting the bite right when we go from side to side. That's basically it. And there's a lot of rubbish talked all the way around it, but we just got 5 basic principles, which I'm going to introduce you to today. And if we get those 5 principles right, we're going to get predictable success every single time. So what do we see here? We look on the left-hand screen, and let's just go through the teeth and see what we see on the teeth. First of all, upper central incisor. What can we see on that incisal edge? You can see there's a bit of wear taking place there. Lateral incisor looks the same length, if not even a little bit longer than the central. So something's happened there, that the central's worn down. The lateral's now becoming slightly half moon shaped here. So wear's occurred there. Let's look at the opposing teeth. You've got a wear facet, beautiful wear facet occurring here. You can see another one just there. Maybe there's a hint of dentine starting to be exposed. We move on to the canines. The canines, which should obviously be pointed teeth, are no longer pointed. They've worn down. We now look at the posterior teeth. So this is my patient going into a right lateral excursive movement. So from intercuspal, they're slid out to the right. They're slid out until their canines are more or less edge to edge. And as you can see, every single upper tooth and lower tooth are now more or less sliding together. So we'll call that group function. Okay, definition of group function: 2 or more teeth sliding into lateral excursion, discluding the non-working side. I can't see if it's discluding the non-working side or not. But let's now think about bruxing. This patient is going to now brux at night. What's going to happen? As we brux at night, those 2 teeth are wearing down, those 2 teeth are wearing down, those 2 teeth, etc., etc. They're all wearing down. We're like a cow going from side to side now. All the teeth are going to start to wear down. As the teeth wear down, we'll come on to this a little bit later, the guidance starts to get shallower and shallower. The guidance gets shorter and shorter. And there's a greater chance that a balancing side contact will now come into contact. As we come into contact with a balancing side contact, that starts to create class 2 leverage. And we'll talk about the theory of levers and how detrimental class 2 leverage is. So what do? We do a simple canine rise. So this is now just a composite that's been placed onto the upper canine to replace its shape. Maybe we put a little bit of a bevel on the palatal aspect, a little bit of a bevel on the buccal aspect. With today's composites, as you can see, initially when they're done, at least, it blends in very, very nicely to the tooth. You can't see the restoration there. We've got lots and lots of enamel to bond to, so it's going to be strong. It's not going to come off. It may wear down, it may chip, but it's certainly not going to come off. And what we've done, what have we done? We've gone now and lifted. We'll call this thing lifted. We've produced a canine rise, which has now lifted in right lateral excursion all the rest of the teeth apart. So when my patient now bruxes to the right-hand side, all he's going to be doing is slowly wearing down that one composite and protecting the central, the lateral, the premolars. Okay, I'm stopping a balancing side contact from occurring, class 2 leverage from occurring. It's such a simple thing to do. And with all due respects, I don't know my audience I'm talking to, but if I'm talking to the UK, and in the UK, most of the dentistry is done still on the NHS, about 60% of it. And most NHS practitioners see maybe 20 to 30 patients a day. I say to my guys who I'm teaching in the NHS, you should probably be doing at least 3 or 4 of these a day. Every single patient you're seeing, probably 80 to 90% have got occlusal problems. Probably half of those, 40 to 50% of your patients, would probably benefit from a simple canine rise. Stop any further wear from occurring. Time out. Let's now think about what's happening. Let's think about the rest of these teeth. Do they want restoring? Does the patient want to have some veneers in place? The canine rise is now protecting everything. And that's the first thing they should be looking to do, is go and test out your new occlusal scheme, especially if it's a small scheme, it's not a full mouth reconstruction. Test it out with composite. Put a composite canine rise back in place. Now, obviously, this can get worse and worse, and it can affect more and more of the teeth. And when it affects more of the teeth, then very often it may not just be canines that we're doing. It may be that we're going to be doing bigger composite restorations. Composite restorations on the whole of the anterior teeth. So in protrusion, in right lateral, in left lateral, we've got disclusion, we've got class 3 leverage, come back to it a little bit later. Our goal of therapy, our goal of treatment is always to produce class 3 leverage. Okay, so from an occlusal point of view, boil it down, you have one thing to do in life with the occlusion, is identify any class 2 leverage in the mouth, get rid of it, replace it with class 3 leverage. That's all you have to do. There's multiple ways to do it, but that's your raison d'etre for working with occlusion. So we're now going to come on to ceramic, and I'm going to go through quite a few cases of using ceramic. And we're going to go from non-preparation, so ways of treating wear and erosion, non-preparation, all the way up to full mouth reconstruction. Okay, so we're going to show you, as I mentioned earlier, you put 10 dentists in a room with the same patient. We've got 10 different treatment plans. We've got 10 different ways of doing it all. So I'm not saying now that this is the only way to do it. We have multiple ways. So I'm going to show you some ways where we do no preparation, some ways where we do some preparation, and some where we do a full mouth reconstruction. Okay, and it's up to you to understand which way we do each case. When do I do it this way? When do I do it another way? So let's look at our first case. The goal of my treatment is going to be to create some space so I can restore. I can either restore in composite or in this case in ceramic. And when I do restore, I want to restore with a different style of occlusion. Because remember, that definition of being an idiot is doing the same thing time and time again and expecting a different result. So if our patient has got a worn dentition, an occlusal problem, if we restore them to exactly the same way as they were before, guess what? The same thing will happen. So again, we have to have time out and do something differently. And in this case, we need to start thinking about reorganizing the occlusion. So here's our first patient. Let's look at him and see what we can see. We can see that, well, first of all, give you some background. He is 44, 45 years of age. He's highly stressed. He owns hotels, and he comes to me, and you'll see his problem in just a minute. Okay, what can we see? We can see, first of all, that we've got some faceting going on here. Look at the upper left central incisor. Look at the lateral. We've got some wear taking place here, a chip out of that one. What else can you see? I can see an awful lot of translucency in there. We've got erosion taking place on the labial surface as well. So it will come as no surprise to you that the palatal aspects now look like this. So, simple case of erosion. There's probably a little bit of wear going on there as well, a bit of a bruxing, but this is a nice combined case where we've got tooth wear due to bruxism, and we've got erosion on top of each other. Okay, what do we see? We see the erosion, we see the dentine exposed. His major problem is his front teeth are sensitive. He realizes that they're feeling a little bit thin. He can see through them in parts. I'm looking at these teeth and thinking, yes, they are getting very, very thin. And what I want to do is I want to bond some restorative material onto the palatal aspects to get rid of the sensitivity, obviously, but also to give them some bulk and some strength back again. What's my problem? My problem is I have no space. So my lower incisors are now hitting into that very worn palatal aspect. And this is a very interesting thing that we have to understand. We're going to talk through this presentation about vertical dimension and what happens to vertical dimension as we go through life. The first thing I'd like you to remember is that we have compensatory mechanisms. Those compensatory mechanisms are called alveolar bone growth and cementum deposition. And guess what, guys? That is happening throughout life. If I go and take an upper 5 and grind it down, what's going to happen to the lower 5? It's going to over-erupt. This is happening all the time, this over-eruption. So we have alveolar bone growth, cementum deposition, which has meant that even though I've worn the palatal surface away and lost maybe 2 millimeters or so, my lower incisor has now over-erupted by 2 millimeters into that area. So if I'm going to put some restorations in here, I have no space. So let's look at ways of creating space. Okay, I've got 4 ways of creating space. Let's look at the easy ones first of all, because sometimes the easy one is the route that you take. Let's look at the lower incisors. Are the lower incisors over-erupted? If the lower incisors are over-erupted, then by all means, grind them down, reshape them. From time to time, you're going to find maybe the occlusal plane is wrong. Especially we see this in a class 2 div 1 patient from time to time, class 2 div 2 as well, where the lower anteriors over erupt. Aesthetically, they don't look very good because you show too much tooth, and especially if the incisal edges are jagged, the patient may well benefit from having the lower incisors reduced. So we don't do it that often. We don't particularly want to do it with healthy teeth. We don't want to take tooth tissue away for no reason, but it's an option for some patients. And I'll show you a case of that later. Number 2, increase vertical dimension. So let's increase vertical dimension around the whole mouth. So how can we do that? We could do full crown work, but that is going a bit OTT for this. Let's look at the rest of the dentition. And here's his upper study cast. And what can we see? We can see he's got fillings, worn fillings in his premolars, occlusals. We've got a large MOD composite, I think amalgam or composite there. We've got an MO here. We've got a worn MOD there, an occlusal here, an occlusal and occlusal. So all his posterior teeth are now restored. So we could simply, in its easiest form, just go back and redo those restorations. But instead of having cusp angles which are quite steep and a deep fosse, bring the fosse up a little bit, make the cusp angles a little bit shallower. That's increasing vertical dimension at the back of the mouth only by replacing worn restorations. And that way we can then create some space at the front. So very straightforward way to go and do it. Quick question aside, if you are going to do that, then important we do it the right way round. Do we do posteriors first, jack open the bite, jack open the anteriors, and then fill in the anterior space with our composites? Or do we do the anteriors first, jack open the back, and then restore the posteriors? Let you think about that. Okay, answer is always do the anteriors first, because the anteriors are not only there to create an occlusal stop, the anteriors are there for aesthetics, anteriors are there for phonetics, and the anteriors are there to give you anterior guidance. So we have to test them first of all. If we've done the posteriors first and set a certain vertical dimension and then fill in at the front, what happens if the patient's really struggling to speak? We're now in a dilemma. So always do the anteriors first of all, put the restorations in place, get the aesthetics correct, number 1, get the occlusion correct, so we've got good protrusive and lateral guidance and disclusion at the back of the mouth, get the phonetics right, and when that's right, fill in the spaces at the back of the mouth. Always anteriors first, posteriors after. That's our second option. Third option is an occlusal one. 90% of our patients have a slide from retruded contact position to intercuspal position. We'll talk more about occlusion in a little while. That means that if I take 90% of my patients, if I take them back to the condyles being in RAP and take them back by manipulation to retruded contact position, as far as I'm concerned, ideal position of condyle in fossa, that means that there'll be space between all the rest of the teeth. And if I've got space between all the rest of the teeth, I can now fill in that space. Now, especially if I've got a horizontal slide, okay? 10% of slides are horizontal. 90% of our patients have a slide. Do your own math. That means 9% of your patients have got a horizontal slide. What does that mean? That means that this is the incisal relationship at the moment in intercuspal. When I now manipulate them back to retruded contact position, the lower incisors move back to here. I now go and do an occlusal adjustment. So I have a posterior stable dentition at the back, and my lower incisors are still here. All I do now is restore the palatal aspect to contact. So a way of creating space is eliminating a horizontal slide, not eliminating a vertical slide. You won't gain space that way, but eliminate a horizontal slide. 9% of patients have them. And one of the options there is that you can then restore the anteriors back into contact. So that's our third way. Our fourth way, and the way I'm going to describe to you now, is a method that was first discussed in 1970 in Scandinavia, and this is called the Dahl appliance. Okay, DAHL, Dahl appliance. And this is basically an orthodontic appliance. Björn Dahl, a restorative dentist back in Sweden in the 1970s, came up with this concept, and it's an orthodontic appliance like a bite plane, like an anterior bite plane, that's when it's placed on the anterior teeth, if it's done correctly, and I'll show you how, it encourages intrusion of the lower anteriors over eruption of the posteriors. Once the Dahl appliance has done its work, we take it out and we have space between the lower anteriors and the upper anteriors. So let me walk you through this case, and I'll talk about the Dahl appliance as we go along. So number one is we mount our study casts. So this is going to be the idea behind my treatment for the anterior erosion, create space with the Dahl appliance, and then I'm going to restore them with prepless palatal veneers. So number one is mount the study cast around RAP. That's number one. Number two, have a look at the amount of space that you've got. And what we're looking to do is create at least the amount of space needed for the restoration that we're going to be doing. So in this case, I need a minimum of 2 millimeters, maybe even 3. So mount around RAP, open up the pin now until I've got at least 2 to 3 millimeters of space anteriorly. That's stage number one. Part two, the Dahl appliance is made, its standard technique, its original concept was linked Maryland style wings. In fact, the first Dahl appliance that was discussed was in fact a chrome cobalt denture, a small denture, which was fitted onto the platal aspects. Because this is 1970, before we're doing Maryland's acid etching, etc. So it was a removable chrome, which was worn. But now we've moved on to either, as you see here, splinted Maryland wings, acid etch adhesive wings, or we can do it in composite. Okay, I'm doing it classically here. I'll tell you how we can do it in composite a little bit later. And what are we doing? So these are now 2 to 3 millimeters thick. You'll see that they've got a certain shape to them. So you can see that we've got a palatal shelf. This is hugely important. The idea of the palatal shelf is so that when the lower incisors hit this shelf, the technician waxes up the Dahl appliance. So the shelf, the angulation of that palatal shelf, hits the lower incisors at 90 degrees. So the lower incisors, the first movement that occurs is the lower incisors get pushed down their long axis. So they get intruded down their long axis. Think for a second what would happen if that ramp, that shelf was not there and we just created a thick inclined plane. The lower incisors would now hit this thick inclined plane. All the rest of the teeth are apart. What will happen to them? They'll be forced lingually. They won't be forced down the long axis, they'll be forced lingually. We'll gain some space. We'll get some over eruption of the posteriors. We'll take the Dahl appliance off. We will think we've got adequate space. We'll restore the anteriors. That's fine. But what's going to happen long term? You've now pushed those lower incisors lingually. What's going to happen with the tongue? Muscles always win. You know this, guys. Muscles always win with any orthodontics. So the muscles, the tongue will now start to push those lower incisors back into the rightful position. And that will either lead to mobility of the uppers, mobility of the lowers, pain, or the upper anterior teeth maybe even drifting forwards and losing aesthetics. So, number one, mount around retruded axis position. Why am I saying that? If you mount around intercuspal and you increase vertical dimension and make this Dahl appliance, what happens when you put the Dahl appliance in the mouth? No posterior teeth, no interdigitation. The condyles are going to go back up to RAP. What's going to happen in the relationship between that ramp and the lower incisors? The lower incisors may end up going back to here on a different area of the ramp again, in which case they'll get lingualized again. So number one, mount around RAP, not ICP, hugely important. Number two is get the ramp so it pushes the lower incisors downwards. And then we wear this for a period of time. It's cemented in the mouth with glass ionomer cement so we can get it on and off when we want to. And we wait for over eruption to occur. Now, we talked earlier, predictability. Predictability of dial appliances. How predictable are they? Very predictable in the young patient, not as predictable in the older patient. We know, we've mentioned already, alveolar bone growth cementum deposition. Okay, this is cellular turnover. What do we know to cellular turnover as we get older? It slows down. So the amount of over eruption that will occur and the speed of over eruption will get slower and slower as we get older and older. So the dial appliance is for the younger patient. What do I call younger patient? 50 and under. And if I was doing the dial appliance now, if this case was somebody in her 20s, I'd expect the dial appliance to have done its job in probably 4 to 6 weeks. Somebody in her 30s, that's 6 to 8 weeks. This guy's in his 40s, I'm expecting 3 months. 50s, 4 months. I'm getting 50, 60, 70. This might take 6, 9 months, 12 months. It might never happen, or it might be occurring so slowly that the patient is getting fed up of the actual treatment. So it's very much predictable in the younger patient. The older the patient gets, the less predictability we have. Okay, so we are waiting for over eruption to occur. What's it feel like for the patient? What do we say? Is this going to cause pain? Answer, no. They have to be splinted. Guys, this has to be splinted. If you do this with individual ones, and this is some of the problem I have with composite, some people like to try to cheat, get around it quicker, and therefore just do the final restorations themselves, final restorations initially, and then leave them and let the posteriors over erupt. Well, two things can happen there. Doing the final restorations freehand, we might not get the intrusion, we might get lingualization. We mentioned that's a problem. And what else could happen? If we don't splint those anteriors and we leave just the 4 front teeth high, we can get one of those teeth starting to drift forwards. So it's essential we also splint. So rule number 3, we have to splint. And we now wait. The patient, is it going to be painful? No. Is it going to be comfortable? Well, it's going to be a little bit uncomfortable for the first probably couple of weeks or so. But if you think about, if I'm opening up the anterior by, let's say, 3 millimeters, then that's basically the molars, second molars are out of contact by about 1 millimeter. You know, the 3 to 1 ratio, maybe 2.5 to 1, but we'll call it 3 to 1. And how long is it going to take for a molar and a molar opposing each other, each of them to over erupt by 0.5 millimeter? Probably a couple of weeks. So within 2 weeks, we've now got a tripod. In dentistry, hugely important, tripods. Tripods everywhere gives us stability. So as soon as we get past the first couple of weeks, the patient will feel more and more comfortable. And over a period of time, the 7s come in, the 6s, the 5s, the 4s, and the K9s are the last ones to come in. So here we are, the time that we've cemented these in place. And as you can see at the moment, K9s are around about 1.5, 2 millimeters out of contact. And we just wait. And we see our patient on a routine every 2-3 weeks, something like that. And we watch. And as you can see what happens, here's our initial starting point. This is maybe after about 4 weeks, 6 weeks, something like that. Back teeth are in contact. And we're just waiting now for these to come into contact. What's our end point? Our end point is the K9s all the way backwards, hold shim stop. Sometimes with the older patient, some of our patients start pushing us, when can I start treatment, when? And you know what, from time to time, we may start to do the definitive treatment without all the teeth still being in contact. And we have 2 options. We either wait a bit longer, but still restore and wait for the other teeth to come into contact, or add just a little bit of composite onto the palatal surface somewhere to get contact. But ideally, classically, we wait for all the teeth to come into contact with shim stop, We then take the doll appliance off, and hey presto, I have space. Okay, which is what we wanted. We could get the space by grinding the teeth, by opening vertical dimension, by doing a occlusal adjustment, or the doll appliance. There's probably other ones, but those are the ones that I'm talking about now. And all we do now is simply take our impressions and restore them. So this is upper impression, and we've got the model silver plated. As a prosthodontist, I love silver plated models, silver plated dies. Nearly all of my work is done on silver plated models and dies. I don't like the normal stone. They can chip and abrade very, very easily. Obviously, we're doing more and more digital work now. But these are non-preparation, so simple impression. Put the doll appliance back as your temporary, otherwise you're going to get that over-eruption of the lower anteriors. So the doll appliance goes back as your temporary. And then all we have is the final end result. And the final end result looks exactly the same as the initial, apart from the fact that you cannot see through these teeth. These teeth are now thicker and stronger. So our first case, doll appliance and palatal veneers. Minimum preparation to the extent no preparation. Let's look at our next case. Next case, we're going to go and do a little bit more. This is going to involve a complex case where we're going to do anterior crowns. We're going to do 5 to 5 anterior upper restorations, but we're still going to use the doll appliance principles to help us gain space. Okay? As you all know, we can gain space, we've talked about it, by either opening up the vertical, by maybe in terms of crown work, grinding down the palatal aspects of the crowns, but also think what happens if you did 5 to 5 crown preps, did minimal or no preparation on the occlusal surface and palatal surfaces, put your prototypes on, your temporaries, I call them prototypes, put your prototypes on and leave them high for a period of time. What will happen? The 6s and 7s will come back into contact, re-establish contact. You've now opened the vertical up all the way around without having to have done anything to good 6s and 7s. And the doll appliance has meant that you didn't have to do any palatal or occlusal preparation. So I use a lot of doll appliances to get this movement when I'm doing crown work as well, just so I can minimize the amount of tooth prep that I do. Anyway, let's look at the case. So we have typically the guy again is about 45 years of age. You'll see from his teeth, he's a horizontal clencher and grinder, side to side. What I'd like you to look at here also is his aesthetics. So this is combining occlusion, doll appliances, and aesthetics. And what's the first thing you look at? Aesthetics here. The thing that stands out for me is his lips. His lips look weird. They're strange. Okay. And why are they weird and strange? They're weird and strange because this is a normal smile. This is his exaggerated smile, his like this. And his lips are exaggerated because for the last 20 years or so, he's been smiling with his lips pursed so that he's trying to protect anybody from seeing his teeth by making his lips into a certain shape so that he doesn't have to show the teeth which he is very, very worried about and embarrassed about. Now, this is a really important part. If I'm going to do some anterior restorations, you know yourself, there's an intimate relationship between lower incisal edge position and lip, upper incisal edge position and lip. And that relationship changes throughout life. As we get older, as we know, our musculature drops down and we see a lot more lower tooth, a lot less upper tooth. So when I'm doing any aesthetic dentistry, absolutely essential that I get that relationship between incisal edge and lip correct. What can I do here? His lips are so distorted, I don't know the correct position for the lips. Therefore, how am I going to get around that? I'm going to get around that by putting some prototypes in long term. So rather than doing some crown veneer preparations, 2 weeks later fit them, I'm going to put my prototypes in. I'm going to leave them for 3 months, even 4 months. so the patient can get used to his new smile. His lips start to relax as he becomes more comfortable, and then I can get the true relationship between incisal edge and lip, and then I can go to my definitives. Okay, so in my own mind, forget doll appliances for anything else at the moment. For my own mind here, this patient has to wear his prototypes, provisionals, temporaries, call them what you will. He has to wear his prototypes for 3 to 4 months so that his lips can relax. That gives me time now also to incorporate doll appliance principles into the prototypes. So we take our photos, and you can see other thing that's interesting here, and this is a clue. We're going to talk about vertical dimension I mentioned in a minute. How can we tell if somebody's lost vertical dimension? Answer is we can't. We may have a bit of a gut feel that somebody's lost vertical, but we have no way of knowing how much vertical is lost, what his vertical should be. We may be able to say what his vertical ideally would like it to be, but we've not got any real knowledge of if somebody has lost vertical. Reason being, we do not have standardized photographs of him every 5-10 years of his life to see what's happening to his nose chin distance and how much of that is physiological in any case. But we can get an idea from time to time. So if we have somebody who goes through wear slowly, normal wear, then as I said before, we'll get over eruption. What are we seeing here? This is the M position. Look at me, okay? M. You see teeth. Why are we not seeing teeth here? Maybe we're not seeing teeth because that over eruption is not occurring quickly enough. So the physiological rate of over eruption is happening much more slowly than the actual rate of wear. So when you do the M position, if you don't see teeth, really good indicator that somebody's lost vertical dimension. So we start to look at his teeth, and as we can see, we're a horizontal bruxis. So this is his intercostal position. You can see his edge to edge. Another question to ask you, does that mean that he's really a class 3 patient? Or is he posturing? And if I take him back to RAP, will he go into a class 1? Or again, is this a vertical dimension loss? Okay, because we're opening on a hinge, as you know, like this. What happens when we lose vertical dimension? The lower teeth come forwards and upwards into more of a class 3. So this, for me, is somebody who started out as a class 1 occlusion, normal overbite and overjet, and over a period of the last 10, 15, 20 years, he's been wearing them down. The vertical dimension has reduced. The chin's got closer to the nose. The lower anterior teeth are coming upwards and forwards, and we're now into a class 3. So what I want to do as part of my overall treatment plan is restore him back to a class 1 occlusion. I'm always trying to restore to a class 1 occlusion. Why? Simple. Class 1 occlusion, lovely overbite and overjet. I've got great guidance. So I'm always going to try to get there if I possibly can. So we've done a little bit of bleaching just to make them a little bit lighter because we're going to be doing some translucent restorations in place. So my goal of treatment here, create space for restorations, establish a reorganized occlusion. So I think it's important now that we start to talk about occlusion and our 5 principles. Okay. As I said earlier in the introduction, one of the problems we have in dentistry is that occlusion does not get taught enough at university. I'll give you an instance for me anyway. I think it was probably 3rd BDS, my 2nd year at dental school. First year was all about anatomy, physiology, biochemistry. 2nd year, we spent 1 full term, okay, doing medical microbiology and oral pathology. So that was 1 day a week over a term. The term lasted 12 weeks. So that's 12 full days we spent. Now, number 1, have I ever in my last 40 years of clinical dentistry looked down a microscope and was able to identify Langham cells, for instance? So the medical microbiology, bacteriology, oral pathology, looking down a microscope, has it been any use to me whatsoever? Answer is In a practicing career, no. It may have been useful for one or two of you from time to time. How many lectures did I have on occlusion? I had 2 lectures. 9 o'clock till 10 o'clock, 2 days. I may have had a bit of a hangover that day as well as a student, so I may have missed one. It would have been great for me, for all our dentists, to have had 10 days of occlusion. 10 days of occlusion would have been fantastic. I can teach everybody occlusion in 6 days. We do it on our courses that we run in the UK, a 6-day course on occlusion. And then you know all of it. You start to be able to put that into practice. So our problem is we're not taught it at university. And therefore, when I start to teach people about occlusion, the amount of knowledge they have is probably about on the undersurface of the sole of their shoe, and I've got to get them up to here. And that's a steep curve. Let's look at composites, adhesion. Okay, you know composites, you taught composites, adhesion at university, at dental school. Therefore, you get out into the big wide world, you see some of the top people talk about composite and adhesion. You can understand it. You can increase your knowledge by 5, 10, 15%, and you're there. But with occlusion, most dentists have so little knowledge to start off with that it's such a steep learning curve. So let's go through it. I'm going to spend 10 minutes on it now. Number 1, let's make it easy. We have 5 principles. That's all, 5 rules. Learn 5 rules. And this is all about getting the bite right when we go up and down. Getting the bite right when we go forwards and backwards. Getting the bite right side to side. That's all occlusion is. First rule, okay? And people get put off by the nomenclature. We've got 2 types of nomenclature. We've got the gnatology nomenclature, which you can see here on the screen. We've got the Pankman-Schuyler-Dawson nomenclature, which is centric relation, centric related occlusion. And we have to go and learn both languages, okay? It's tough, but you have to spend a bit of time. You're an intelligent person. You passed all of your grades, all of your exams to get into university. You're qualified. You're an intelligent person. Do not tell me that this is beyond any of you. If you want to take the time to learn it, do go and take the time to learn it. It will make you a better dentist. What will it do? It will give you predictability. That's what we're after, predictability for all your restorative, cosmetic dentistry. So, first principle, RCP equals ICP around RAP. What do we mean about that? We mean, first of all, get the condyle into the right position. The ideal position of the condyle in the fossa is in its most superior. Some people talk about anterior position, but in its most superior position, condyle in the fossa. Okay, why is that? Well, number 1, it's reproducible. Okay, intercuspal position, and a position which most of you will work to, is not reproducible. Okay, RAP is reproducible today, tomorrow, 5, 10, 15 years, 30 years later. I can get to that same position. I can teach dentists. Okay, 1, 2, 3, 4, 5. I can teach a whole class of 30 dentists to get that same position. Okay, it's beautiful, reproducible every single time. What about intercuspal? Intercuspal is not reproducible. Intercuspal changes all the time. Okay, quick favor. Put your head back like this, horizontally. Okay, close your teeth together. Which teeth hit first? Your back teeth. Okay, put your head forwards, downwards now, into like a feeding position. Close together. Which teeth hit first? Front teeth. Question to you. Which is intercuspal? Which one are you going to work to? So gravity affects intercuspal position. What's the definition of intercuspal? Maximum intercuspation. Position of maximum intercuspation. What determines intercuspal position? Shapes of teeth. How they fit together. Okay? Shapes of teeth. So your intercuspal position is based on the shape of your teeth. What do dentists do every single day of their life? Change shapes. What do you think happens to intercuspal? It changes. Okay, intercuspal position also dictates position of condyles. So condylar position is changing all the time as we do dentistry, if we don't do it very well especially. So dentistry changes intercuspal. What else? We mentioned muscles bringing the teeth together into the correct position. What happens with muscles? Okay? Have you ever woken up in the morning and closed your teeth together and gone, oh, that's strange. My bite feels really weird today. I do sometimes. I know that I've been clenching and grinding that night, and my muscles are a little bit like this, tense. So it's now bringing my teeth together into a different position. What happens if I now go to the dentist and I have some crowns done today and I have a jaw registration? I come back 2 weeks later, I've had a blissful night's sleep. My jaw position 2 weeks later and my jaw position today, different. What happens? We now put the crowns in, the bite's wrong, we have to go and grind and clench, etc. We're losing predictability. Isn't it easier to work to a reproducible position? RAP, work to it time and time again. It's reproducible every single day. What else is good about it? Muscles are at their most relaxed. Okay, think logic. One of the problems we have at dental school is we're not taught to think logically. We taught a lot, too much biology. We mentioned that already with medical microbiology, bacteriology, etc. So we're taught too much biology and not enough mechanics and engineering principles. Occlusion is not about biology. Occlusion is about mechanics and engineering principles. So if we are now going to engineer the new robot, the robotic form of a human being, would the first thing you do be to have a joint where the lower part is not being loaded through the center of the upper part? Because that's what 90% is happening to our patients. 90% of our patients, their condyles, this is you as well, the condyles are here. I'm exaggerating, not exactly there, but the condyles are forwards and downwards on the eminentia. So rather than being in that midmost position, that stable bone brace position, the condyles are forwards and downwards on an inclined plane. And we now function, Brooks and clench and grind, on an inclined plane. What do you think that does to the stability of the joint and all the muscles? It makes common sense. So the idea is try to get all the teeth together as the condyles are in RAP, the most muscular relaxed position. How do we do that? We do an occlusal adjustment first of all. I'm not talking equilibrations here, guys. I'm not talking going to the nth degree and spending hours and hours. I'm talking about doing a gross adjustment to get rid of the retruded contact position. So here's a guy who I'm manipulating around RAP. His first contact is in the second molar area. You can't just see it, it's up here somewhere. All the rest of his teeth are apart. That's retruded contact. And what happens? Does he walk around in that position? Of course not. If he walks around in that position with one point of contact, you know what will happen. One of those teeth will get painful. And if it gets painful, they get pulpitis. And the body knows that. Body has a fight or flight reflex, vasovagal reflex. So what does the body do? The body says, stop. Do not go around with your joint and muscles in the right place. No, that means that two teeth are contacting. What I'd like you to do is push your jaw forward and now open and close. And guess what? You don't hit on that tooth anymore. Problem solved. We don't get pulpitis. We've got rid of pain. However, we will now get long-term chronic damage in our teeth, the clenching and grinding, the wear faceting, the abfraction lesions, the recession, and also potential with muscles and joints. So all I'm talking about here is doing an occlusal adjustment. On 90% of patients, they have the ICP slide. 90% of those, that's 80% of patients, have a vertical slide. Vertical slides are easy to adjust. Absolutely simple, easy to adjust. So 80% of the time, it's a slam dunk. Patients suffering from occlusal disease, what do? Treat the occlusal disease, restore. This is one of the ways, not all of them, one of the ways. Number two, okay, when you're restoring, make sure you create a mutually protected occlusion. Okay, what's a mutually protected occlusion? Well, pathologists, I believe it, that certain teeth have got roles to play in the masticatory system. So what's the role of the back teeth? To clench and grind the food, okay? What's the role of the front teeth? To incise. So what we're talking about now is that back teeth should take vertical loading. Front teeth should take horizontal tearing, horizontal movements. So what I want to happen with my mutually protected occlusion is that when I tap up and down like this, I want my back teeth to hit just before my front teeth. Okay? And that's usually in the region of 10 to 20 microns. So back teeth take the shock absorbance. You know yourself, somebody who doesn't have back teeth, okay, what happens to their front teeth if they've got no back teeth? The front teeth slowly start to drift outwards, don't they? Why? Because anterior teeth cannot take vertical loading. So set up your occlusal scheme in this position with the condyles in the right position, muscles relaxed, flashing up and down, back teeth hitting just before front teeth. We can do that with adjustments. We can do that with restorations. Front teeth 10 to 20 microns apart. What's the role of the front teeth? Role of the front teeth now is to guide movements in lateral and protrusive, the horizontal movements. So back teeth come apart. You know yourself again. If as you grind from side to side, back teeth come together, then cusps are likely to do this, to fracture off. We could get pain somewhere in the masticatory system. So this is our mutually protected occlusion. And we need to make sure that we get this into our restorations. So here is an unusual case, but it shows you how we go to, what extremes we go to get this mutually protected occlusion. For me, it's predictability every single time. And I can look patients in the eye and say, we will get a good result, a long-lasting result. Okay, so what do we see here? We see a patient who's got canine to canine bridge, 6-unit canine to canine bridge, replacing the 4 anteriors. So we got 4 pontics here, the 4 incisors. I've then got a fixed movable bridge one side, fixed movable bridge the other side. So some classic restorative dentistry, all PFM. Now let's look a little bit closer, and you can see this palatal aspect here looks a little bit strange. What you'd normally look to see is that the palatal aspects would be sculpted so that these look like pontics and teeth, and they sit on the gum like this. So now I've got about 2 to 3 millimeters of extra porcelain fused to metal, like a table hanging backwards. Okay, think about it. Why? Okay, let's give you some history. Patient's 40 odd years of age. Lost a lot of teeth, been through NHS treatment, not been very good, lost teeth, but she's a class 2 Div 1 patient. Her lower anterior teeth are like this, no contact on the uppers, okay? So she's got no anterior tooth contact, therefore she's got no mutually protected occlusion. The anterior teeth cannot protect the posteriors. So if I left her with a normal bridge like this, with no anterior guidance, if she brooks and clenched and grind, okay? Not all patients do, but if she did, she'd be clenching and grinding on her back teeth, okay? And what do you think would happen to my porcelain? It's going to do this. All that stress, remember that's class 2 leverage, talk about it in a minute, that stress goes to the joints. We want class 3 leverage wherever possible. We want the anteriors to protect the posteriors. So what have I done here? We've created this ramp. Undersurface is totally convex, so we've shaped it so it's cleansable on the undersurface. And yes, the patient wears it in a prototype for a period of 3 months, first of all, just to make sure that they got used to it. And then the patient, we transfer the patient to the definitive restoration. Okay, but that takes a little bit of time, 3 months to get used to it. But the idea is now patient contacts here and here and here and here. And when we go into protrusive and lateral movements, back teeth come apart. Mutually protected occlusion. Next one, anterior guidance. What's anterior guidance? Anterior guidance is the influence of teeth over mandibular movement. So that's the definition. We put a caveat on it. And the caveat that goes on it is preferably anterior teeth. So anterior guidance is the influence of teeth, preferably anterior teeth, over mandibular movement. What's posterior guidance? Posterior guidance, influence of condyles. So with anterior guidance, what we're looking to do is make sure that the front teeth dislute the back teeth. Okay, close together, all of you. Slide your jaw from side to side with your teeth together. What's guiding the way that your mandible moves is teeth. Teeth are guiding, that's anterior guidance. Next thing, open, teeth slightly apart, move your jaw from side to side. What's influencing the way that your jaw, your mandible moves? The shape of your condyles, the fossa. And all of you will move in a different way. You have a new, unique way. Just like iris recognition, thumbprints, you'll have a way that your mandible moves, okay? Completely dictated by your shape of your teeth, anterior guidance, shapes of your condyles and fossa, posterior guidance. So we look at anterior guidance in two ways. We look at it as protrusive and we look at it as lateral. So first of all, in protrusive guidance, straightforward. Remember, we've got our rules and regulations. Okay, in protrusive guidance, I want my lower four teeth sliding on the palatal aspects of my upper four teeth, back teeth come apart. Okay, simple rule. Now let's look at lateral. Lateral guidance. The normal lateral guidance we have, canine guidance. Okay, and the canines are great teeth. They're the longest lasting teeth. They're big and strong. They're in the right position. It's easy to do. They've got long roots, etc. So the canine is the first choice. And when canines grind down, then we drop naturally on to some form of group function. But the canines are there to protect. So we go for canine guidance wherever we possibly can. However, let's just go back one. Are there any instances where we wouldn't use canines? And the answer is yes. Think about when you give somebody guidance. When do you go into guidance? All right, guys. Do you, at the end of this presentation, go outside, have a cup of coffee, smoke a bit of fresh air, and say to yourselves, I think I'll just go into guidance for a couple of minutes? When to do guidance? You go into guidance when you brooks and clench and grind. Okay? That's when we go into guidance, when we go at night time. So what I'm trying to do when I put my anterior guidance into a case is I start to look at teeth which are strong enough to take guidance. So I'm looking at right and left lateral, I'm looking at protrusive. And there are certain teeth that if you put into guidance, the patient bruxes on them, and those teeth are not strong enough to take the bruxing forces. You know which teeth those are. Post crowns, root filled teeth. Sometimes it's pontics. Sometimes a tooth with a large core. It may be a single tooth implant, a mobile tooth. Those teeth are not strong enough to take guidance. So we have canine guidance wherever possible, but we have to be aware that certain teeth cannot take them. They're not strong enough. So if I'm looking to set somebody's anterior guidance up, I'm looking for two things. I'm looking for teeth that are far enough forwards, okay, because that's class 3 leverage. Going to talk about that now. And I'm also looking for healthy teeth. So let's look at the theory of levers. And this is hugely important because this is engineering skills in the mouth. When I do these 5 principles, they're not my 5 principles. These are 5 principles of occlusion that have been laid down by much more intelligent people than me. All I do is adapt them and teach them in a particular way. But these 5 principles have been down there for years and years and years. Okay? The 5 principles are there to create less stress when we brux and clench and grind. Now think about it. That is our sole purpose. We have somebody who's bruxing, clenching and grinding on your beautiful veneers. You can't stop him from bruxing. You can try and put a piece of plastic in, but what happens if he forgets that? Or number 3, this is the important part, we now start to de-stress. Take the stress out of the mouth. Take the force that he can brux and clench and grind with out of the mouth. So this is now our theory of levers. We've got 3 types of lever. And the mouth is a lever. We have 3 types of lever. We have class 1, the classic seesaw. Levers magnify forces, and a seesaw can magnify forces by up to 100 times. We then have class 2 leverage. The classic class 2 leverage is the nutcracker. You've all used a nutcracker. Then our class 3 leverage is the pincers, okay? Is the tweezers that will take a hair out, okay? Let's look at the difference between class 2 and class 3, okay? So a class 2 lever, okay? Let's just look at my hand as being a class 2 lever. Okay, the fulcrum is here. Okay, so what do? Let's look at the nut cracker. So we put the nut close to the fulcrum, and we now put our hand grip as far away as possible. We squeeze, the leverage fractures the nut. Okay, let's look at class 3 leverage. What happens when we go from class 2 to class 3? So again, let's look at the nut cracker. Now with class 3 leverage, all we do is we change the position of the nut and change the position of the power, the force. So class 2 leverage, the nut was next to the fulcrum. What we're going to do now is take the nut and put it as far away from the fulcrum as possible, out here. And instead of us squeezing at the edge, we're going to squeeze somewhere in the middle. So the power will be between nut and fulcrum. Whereas previously for class 2 leverage, the power was a long way away from the fulcrum. Now the nut is a long way away. Okay, what do you think is going to happen? When you have your nut at the end, you squeeze in the middle. What's going to happen to the nut? Nothing. The nut never breaks. Therefore, question for you. If the mouth is a set of levers, do you want your patient to clench and grind in class 2 leverage on your veneers, the nut cracker, or do you want him to clench and grind in class 3? The answer is, of course, class 3 leverage, wherever possible. That means having the teeth that he clenches and grinds on as far away from the fulcrum as possible, with the power unit, the masseter, in the middle. That means, again, anterior guidance should be on anterior teeth. So when I'm looking to put certain teeth into guidance, okay, I'm saying to myself, okay, I'm going to allow you to clench and grind on that tooth, and that tooth tonight, but not that one, that one, that one. And how do I choose? I choose the teeth that are furthest forwards, longest away from the joint, and also those that are as healthy as possible. That's the key to anterior guidance. Fourth principle, no non-working side interferences. Okay, why? Non-working side interference is a class 2 leverage. Okay, here's a nice case. This patient came to see me. I advocated just doing a simple canine rise. Also gave her the opportunity to have a splint afterwards as well. She said no. She went away, came back 10 years later, moved job, came back to the area 10 years later. This is what a dentition looked like. So what had happened, she was about 40 years of age, or she was about 40 years of age here and about 50 here. So what happened in between this time? So up until this time, she'd been clenching and grinding just on her front teeth. Look, the side teeth, fine. Clenching and grinding on her front teeth wearing down, the guidance getting shallower, 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 shallower as the front teeth wear down. Eventually, after 20, 30 years of wearing in class 3 leverage, now as she clenches and grinds, a non-working or balancing side contact comes in. Now she's clenching between her front teeth and the non-working side, balancing side contact. Now we've introduced class 2 leverage. What happens when you clench and grind on class 2 leverage? Cusps fracture off. So suddenly all hell is let loose and we get increased amounts of wear on the front teeth, back teeth where cusps start to shatter. Why? Because it's now class 2 leverage. What's the goal of our occlusal therapy? Said to you earlier, keep on going back to class 3 leverage. See class 2 leverage, eliminate it, go back to class 3. Okay, guidance. Final principle, posterior stability. I want to create good stability at the back of the mouth. And for that, it means 3 contacts, tripodized contacts, wherever possible at the back of the mouth. And the other thing I want is cusp to fossa relationships, not cusps hitting onto marginal ridges. So that's 10, 15 minutes on occlusion. Okay, 6 days I need to teach it to you fully. So let's go back to our patient. We know what we're going to be doing. We've done a little bit of cosmetic imaging on him. Remember, create space, establish a reorganized occlusion. We're going to create space by prepping the anterior teeth 5 to 5, not prepping palatally, only prepping a little bit off the occlusal surface of the 4s and 5s, putting prototypes on which look good, which are high, allow the posteriors to overrut. So we're increasing vertical dimension and therefore taking him back Remember, these are the anterior teeth. Okay, increased vertical dimension. Our anterior teeth drift back like this because we're on a hinge. That allows us the ability to make our front teeth longer. So we start off diagnostic waxing, mounted study cast around RAP, classic diagnostic waxing, get our prototypes made, make sure they look right, make sure they're the right shapes. Look at the occlusal plane. We've come down deliberately. There's our occlusal plane because we've made these longer than they would be normally. We prep the teeth. We don't prep anything off the palatal aspects other than a finish line, keeping all that palatal enamel a little bit off the occlusals, but not too much. We put our prototypes on. We establish a class 1 occlusal scheme at an increased vertical dimension. We've given the patient correct overbite and overjet. He's got guidance, nice and shallow guidance, but it disglues the posteriors. And we now wait. We wait for the lips to come back. We wait for the upper molars to over-erupt. Okay, and this is what's happening now. At the end of 3 months, look at his lips. Beautiful, his lips are now relaxed. End of 3 months, lips relaxed, back teeth in contact. Let's go and nicely restore him now. So this becomes a nice standard case. And we do this in whatever material you want to. I think this is Emax, which I've been using here. And we bond the restorations in place. And we've got some nice looking, even restorations back to a class 1 occlusal scheme. Opened up his vertical dimension. He looks a little bit better. Molars are in contact. But remember, I'm always going to protect. So I'm always going to put the splint in there for protection, just in case my patient, the odd time, doesn't wear it, forgets it, breaks it. Okay, I want to have my splint there in case the patient, again, forgets to wear it or hell may let loose. So I want something protecting it at night time. And there's my final case. So a nice case, which is giving us a combination of tooth preparation, okay, minimizing it, but still heavy. Nobody's getting around it. These are crown preps, but I'm minimizing the amount of tooth destruction. Doll appliances, occlusion principles, creating space. Let's look at the next one. Next one, full mouth reconstruction. We're going to go to full mouths now, increased vertical. We look at this case. So we've got a lot of wear taking place, a lot of missing teeth. Look at the lower incisors. This is a case I was talking to you a little bit earlier, where the lower incisors have all over-erupted. They've over-erupted because this is his retruded contact position, and he slips into a class 3. Okay, so you look at the side teeth in retruded contact, and this is a class 1 occlusion. So he's basically posturing forwards because of his retruded contact position. Okay, so I'm going to restore him now at an increased vertical, but that means his lower anterior teeth are still going to be a little bit high. So I'm going to go and flatten the lower anteriors, and that will give me a little bit more space to take the upper anteriors, that upper one which is retroclined, and move it forwards into an ideal class 1 occlusion. So here's my occlusal view. I'm going to do some bridge design here. We're using Duralay bonnets, coat hanger wire pickup techniques, classic prosthodontic techniques. I've ground down those lower anteriors, not into denting, but so that they look nicer, and it's given me a little bit more space. Do my pickup impressions, make my prototypes, and then my final end result. And again, a class 1 occlusal scheme, fully protected. Okay, 5 principles of occlusion. Right lateral, canine guided, everything comes apart, class 3 leverage. Left lateral, canine guided, everything comes apart, class 3 leverage. Anterior in protrusion, everything comes apart, class 3 leverage. 5 principles, condyles in the right position, muscles relaxed. Okay, predictability is the key. Right, final case, guys. We've been at it an hour and a half now. So this final case is probably going to take us half an hour to finish. But what I want to do is go through in detail, okay, the planning, not the execution, but the planning of this case and why we do it in a particular way. So the first thing we need to think about is if we're going to increase vertical dimension, as we've discussed in several of these cases, how do we increase it? What do you increase it by? How much? Whereabouts do we increase it? What vertical should I work at? So I have 4 verticals which I can work at. Okay. First one is the existing vertical. And if I'm going to do a large restorative case, this is a wear case. Okay. The whole treatment options for the wear case. So a wear case working at the existing vertical does not make sense. The reason being, if it's a wear case, then the teeth have already been ground down a lot. Really, do you want to go and grind down another 2 millimeters on the lower anteriors, for instance, just so you can put 2 millimeters of composite back again? So that does not sound a really good way of creating space for your restorations. Large full mouth case, we therefore work at an increased vertical. So I'm not saying I would never say never, but I can't think of a reason why I would work at the existing vertical dimension. There's probably one out there, I can't think. So 99% of the time, let's say we don't do it. So we work now at an increased vertical dimension. So next question for you is, what is that increase? How do I know? How do I know how much tooth tissue has been lost? How do I know what is original vertical dimension to be? And the answer is we don't. We have to take a guess. So we have 3 different verticals that I can work at. And I put these down as the minimum prep, the RCP, and the facial aesthetics. Let's look at the minimum prep. Okay, so number 1, mount your models on the articulator around RAP. Okay, next thing is, do you have enough space around RAP to go and now restore? Because remember, if we mount around RAP, there'll be a retruded contact position. The case I showed you earlier, there's loads of space between the anterior teeth when I took the patient back to RCP. Okay, so in a case like that, I could work around RCP because I've got space now. So as long as I work around RCP, my technician could do an additive wax up everywhere else, and we build them into contact. Okay. The other one is if I don't have enough space around RAP, so I only have a miniature slide, 0.5 millimeter, 1/4 millimeter. Okay. Now we open up the vertical more until we have less tooth preparation to do. So let's look at this. Minimum tooth preparation, or the if I don't want to do any tooth preparation on the lower incisor, okay, minimum amount of porcelain ceramic composite I need is about 2 millimeters. So if I open up 2 millimeters and work at a 2 millimeter increase vertical, that means that I don't have to do any destruction on the incisal edge or palatal aspect of my uppers. So that means it's just an axial preparation. But remember, if I open up by 2 millimeters at the front, how much does that mean at the back? That's 2/3 of a millimeter. Okay. If I'm doing a PFM at the back, I need 1.5 millimeters. If I'm doing upper and the lower, I need 3 millimeters. Therefore, what would I have to open up at the front to get 3 millimeters on my second molars? I'd have to open up by 9 millimeters. Now that's usually far too much. So when we talk about opening up for the minimal prep, we're talking you and your technician getting together with the mounted study cast, opening up the vertical, as long as around RAP, open up vertical, have to be working around RAP. Rule, you cannot open up the vertical around ICP, because when you open up vertical, you've got no ICP left. So we have to open up around RAP. So models in retreated axis position, open the vertical up so that you get a good compromise between length of lower anteriors, amount of space you've got at the back. So you minimize the amount of tooth prep. So this is by an arbitrary amount dictated with your thought process being, let's try to minimize the amount of tooth prep that I do. Final one, the one I'm going to talk about here, is facial aesthetics. So let's go through this. Let's meet Ivor. Okay, so first of all, look at Ivor. Tell me what you think of it. He's got greasy skin. His hair's not very good. He's got many chins. He's fat in the lower third of the face. Nose chin distance over close. You know what his teeth look like. We're going to show you his teeth in just a second. You know what they look like. They're worn down. Ivor's lost vertical dimension. So we're going to increase his vertical dimension, okay? But we're going to do it to facial aesthetics. So vertical dimension, what do we know about it? It's a dynamic concept, and it gives me the opportunity of improving facial beauty. So when we have a large restorative case that involves wear, I will most of the time, 99% of the time, increase vertical dimension, give my patient a nice looking smile, whatever he wants. That can be a media smile, BL1. It can be a crooked, nice, aggressive, natural smile. But I'll increase vertical dimension so we get better facial proportions. And what I'm looking to do is try to take 5 to 10 years off his face by increasing vertical dimension. Okay, called the dental facelift. And in order to do that, one of the most important parts that we have to plan for now are occlusal planes. We need to make sure that we get the occlusal planes in the right position. We're going to spend some time on that. So let's look at facial proportions. We all know from aesthetics, we've done so much on smile design. Two words, two huge words on smile design, on aesthetics are proportion and symmetry. Symmetry across the midline, so right and left look the same or similar. And the other part is proportion. We know about golden proportion, but let's look at facial proportion. We know from our beautiful people that the hairline to bridge of nose to base of nose to chin should be equal thirds. Okay, so what we're going to do with Ivor is look and see what's happening with the lower third of his face. Another one is we can use golden proportion. So we're going to look at Ivor and we're going to see if we can increase vertical dimension. Okay, if we do, then look what happens. Okay, again, a study in the BDJ, we've increased vertical dimension on patients. 81% of the panel, 4 out of 5 people looking at him says he looks younger. So who doesn't want to look younger in this day and age? And to increase by 5 millimeters seems to be the amount that we need in order to get other people to look and see there's a physical change. Those other people aren't going to go, oh, great vertical dimension you're working at. Love it. Love your new vertical dimension. No, those people are going to say, you look younger. You look better. Have you been away? Have you lost weight? Have you been on a diet? Have you been to a health farm? There's something different about you. They won't notice that it's a vertical dimension. They'll just see you look better. You look younger. You look healthier. If we do increase vertical dimension, some people always have this worry about invading free waist space. Please don't worry about it. We've got this lovely thing called proprioception, which means that if we invade free waist space, as long as you do it the right way, remember, around RAP, we invade free waist space. The first time that our teeth now contact together, proprioception goes centrally, the mandible, the muscles, tells the muscles, this is the new position of your teeth, therefore drop back by 2, 3, 4 millimeters, create a new free waist space. Happens 100% of the time, as long as you're working around RAP. Doesn't happen, incidentally, in denture patients. And that's one of the problems we have. By increasing patients' vertical dimension on full dentures, because there's no proprioception, you know yourself, what do patients say? I can't talk properly. I can't eat properly. It feels like I've got a mouthful of teeth. Okay? Because they've not got the proprioception telling them. So don't worry about that. So let's go back to Ivor. Okay, number one, we're going to increase his vertical. How much are we going to increase it by? And then number one, we need to let that be tested. So let's measure. We're going to measure Ivor from hairline, bridge of nose, base of nose, chin. Okay, we can't do anything about the top two, but we can do something about the lower third. And I want to make the lower third either equal to the middle third or equal to the top third. Okay, whichever is going to be the greater. I want to put him at least until that lower third is at least the same as the middle third, or if not, the upper third. So we get this facial stretching, this elongation of the face, this So we measure it, simple measure it. Do some measurements. Okay, get your dividers on, do some measurements, decide what it should be, how much it should be open by, put it into a copy, put it into a U shape, put it onto the top teeth, make sure it's not impinging on the lips, lie your patient down, by manual manipulation, get the lower teeth to actually just dig into the wax, not all the way through, take the wax out, put it into some iced water so it now goes rock hard. Patient sat up. Now we put the wax in place again, get the patient to close into the indentations, and now we measure. And let's just say that the middle third is 45 and the lower third is 40. And we want to increase this lower third by 5 millimeters. We put the wax in and it's 50. Okay, well too open. What do? We say, okay, either squeeze, squeeze, stop. Okay, it's 47. Squeeze, squeeze, stop. 46. Squeeze again, stop. 45. It's now the right amount. Now we show either. And you all know yourselves. Whether it's ladies I'm lecturing to, men, I say ladies probably a little bit more. You've gone to the hairdresser. You've had a new hairstyle done. Maybe you've changed color. You've gone from long hair to short hair to a bob. You look at yourself in the mirror. What's the first thing you see? You see somebody who's not you. This is not you. And the first thing you see and think about, express, is doubt. You go, oh dear. Oh, I'm not sure. Oh, have I done the right thing? Okay. So 2 things. Number 1, have somebody with you. So either comes in with his girlfriend, his wife, or whatever, to give them their opinion. That's number 1. Number 2, let Ivor take the wax away with him for a period of time at home. Okay, ladies, we've had the haircut done. We go home. What are you doing as you go home? Every shop window you're going past, you're going, looking in the shop window, getting used to this. And guess what happens? The longer you get used to it, the more you come to terms with it. And it really helps when some of your friends say, great, oh, love the new look, it looks fantastic. So don't expect Ivor, when he now brings his lips together, to look at his new face and go, love it. His first thought is, that's not me. So give him some time. So we bring Ivor back 1 week later. Okay. And we now say, okay, what do you think? And he's been trying it in and he might say, absolutely fine. Or, Paul, it's just not me. In which case, okay, squeeze a bit more, squeeze a bit more. And instead of it was 40, it may be that we stop at 42 or 43. We've still increased it, but not the 5 millimeters that we need to make everybody see that this is a new Ivor. Remember, 5 millimeters is the minimum we need for other people to see it. So anyway, we've now got our new vertical that we're going to work at. And of course, that will go to our technician and he will mount the models at that with that wax, drop the incisal pin down, and that's now the vertical dimension we're going to be working at. Okay, so we've found it, he's experienced it, so we're ready to go. These are his teeth. Okay, as you can see, pretty well worn down. We've got over-erupted teeth at the back, we've got missing teeth. So this is a full mouth reconstruction. We've mounted our study casts. Now remember, we've got to start thinking about these occlusal planes. Okay, hugely important. What does the occlusal plane do? Well, first of all, let's look at one thing. I want smooth, flattish occlusal planes. I do not want steps in my occlusal plane. Why? Steps in the occlusal plane mean that a tooth is over erupted or under erupted, and maybe some of the other teeth are over erupted, and it means my guidance now has to be steeper to overcome the over erupted tooth. What I want in my reconstruction, as well as my 5 principles, I want my guidance to be shallow. Remember, the guidance there is where my patient's going to be bruxing. Now, for instance, let's look at a canine. Okay, palatal surface of a canine. And I've got 2 options here. I can either make the palatal surface steep like this, or I can make it shallow like that. What's going to be the best? Okay, let's say if I make it steep. My patient's now bruxing. So my jaw, my lower canine, wants to move horizontally to the left. As he's doing that, he's hitting a near vertical wall. So it will be coming downwards because this is a steep plane. But as he's doing this, there's an awful lot of stress that's now being placed in the masticatory system. The teeth are wearing, there's a lot of stress. One of those teeth could fracture. There's stress in the muscles, there's stress in the joints. Now what happens if I take that steep canine, what happens if I make it very shallow? Patient now does that. So when he bruxes, all the force of the bruxing has been dissipated because it's a nice, easy movement to make. So the masticatory system loves shallow guidance. I love shallow guidance. Shallow guidance works, and it's, again, class 3 leverage, but it's a nice flowing movement. Imagine the ice skater sliding around on the ice, no stress whatsoever. That's shallow guidance. Flat, smooth occlusal planes, no teeth up or down the occlusal planes, allows me to put shallow guidance in place. So, number one, I want shallow guidance. I want even, smooth occlusal planes. It also gives me the aesthetics. It gives me the amount of tooth reduction and any need for crown lengthening if I do have over-erupted teeth. So let's start to work out what my occlusal plane should be. How am I going to do it? Right. Questions for you again. What occlusal planes do you know of? Maybe a bit of a strange question, okay? But we have got certain occlusal planes that we work to in the mouth. Those are called the curve of Spey, curve of Wilson. Those are occlusal planes. Those affect the shapes of our teeth. So anterior-posterior curve of Spey, buccolingual curve of Wilson. Those are two occlusal planes. So a question for you again. When you're doing a full denture, okay, full upper, full lower denture, do you do the lower bite block first? So we've done first inch, we've done second inch. Do we do the lower bite block first or the upper bite block first? Think about it. One's right, one's wrong. Answer, always the lower bite block first. When we do a diagnostic waxing, it's always the lower waxing first. Why? Well, we want to get now as close as possible to the ideal occlusal plane, to the patient's natural occlusal plane, to the anatomical average occlusal plane. We've got those three things. Okay. In the edentulous patient, there's no teeth there. So how do we know where those occlusal planes were? Aha! We know because our science and papers tell us that the curve of Spey not only goes to the canine custip, buccal custip of the 4, 5, 6s, 7s, 8s maybe, but it goes through the superior third of the retromolar pads. So even if we have no teeth, or all the teeth are worn down to stumps, okay, we know that the correct occlusal plane, correct curve of Spey, goes through the retromolar pads. We don't have anything in the upper jaw. The only thing we have is in the lower jaw. So let's make use of that. So remember, for a plane, how many reference points do I need? 3. Okay, 2 posterior, 1 anterior, 2 anterior, 1 posterior. Okay, doesn't matter. I need 3 points for a plane. So I've already got my 2 points in the lower jaw. Irrespective of what the teeth look like, I know that my curve of Spey, my posterior occlusal plane, goes through the superior third. So now all I want is my anterior one. Okay, so what are we going to do for the anterior one? Anterior one, we're going to go to the M position, M, and how much incisal edge we show with our lips at rest. And again, all the dental prosthetic books we've got there, the full denture books, we've got lovely tables, mentioned it earlier. What happens to our face, our muscles? We lose the elasticity and our muscles drop. So a young teenager, when she goes Emma, shows all upper tooth, no lower tooth. A 60-year-old dentist, haggard dentist, ex-professional cricketer like myself, when he goes Emma, no upper tooth, all lower tooth. Okay, so something's changed between teenager and 60-year-old dentist. And that's the elastic component. Happens to us all. So what we need to do now is understand Ivor. How old is Ivor? Ivor's 55 years of age. Question to Ivor. Ivor, do you want your teeth to look 55? Do you want your face to look 55? Or at the end of it, would you like your teeth, your smile, and your face to look maybe 5 to 10 years younger? What do you think Ivor's going to say? He's going to say, yes, please. So we can go and see where our incisal edge position should be for a 55-year-old, but actually I want it to be for a 45-year-old, because I'm going to be setting my lovely smile for a 45-year-old person. So whereabouts is it going to be? Okay, for a 45-year-old person, then we're looking at around about 1.5 millimeters above the lower lip. So that's going to be my third reference point. So 2 posterior reference points already there on the study cast. Okay, how am I going to get the third one? I've got 2 posteriors. How am I going to get my third one? Easy. This is Ivor. This is the M position. Guess what? Again, we don't see teeth there. So we know, or we got a good idea that we've lost vertical dimension. So I'm going to now take a perio probe. I'm going to probe behind Ivor's lips as best I can. Okay, Ivor, Emma, stay like that. I'm going to probe behind the lips, and I'm going to find out where lower, it doesn't matter if it's left or right, I'm going to choose left, lower left central incisor is. So I'm probing behind with a perio probe. So I'm going to probe down to find out where lower left central incisor is. And let us just suggest, in Ivor's case, it's 2 millimeters below the lower lip. So I'm now going to say to my technician, okay, Mr. Technician, please, when you've got that study cast here, what I want you to do is to take that lower left central incisor, and I want you to wax up 2 millimeters onto it, takes it to the lip level, and then an extra 1.5. So I want you to wax up just 1 tooth for now, nothing else, 1 tooth, that lower left central incisor, wax it up so it's 3.5 millimeters taller. And that now gives me my third reference point. I've now got my plane. Now I'm going to go to my mounted study casts. Okay, we've got the 5 millimeters of vertical opening, roughly whatever it was with Ivor. So we've mounted the models at this increased vertical dimension. I'm now going to do a little bit of treatment planning myself. So this is for me. So I put a little elastic band, a little rubber band around the articulator. And obviously I can move the rubber band up and down, which will take this posterior and anterior rubber band position and make it different. So what I'm going to do is I'm going to move this up and down until, as I'm looking from the side, this view, the rubber band is passing about 3.5 millimeters over upper left central incisor. I'm also going to take the rubber band at the back, move it up and down. So looking at the side, the rubber band is going through the superior third of the retromolar pad. Guess what? This is now what my new occlusal plane is going to look like. Hold on. I need curvature to it. So it's not going to be exactly like this. This is my flat representation of a curved occlusal plane. Remember, curve of space, curve of Wilson. I'm going to introduce the curvature in a little bit of time. I'll show you how. But initially, that shows me what it's like. Next thing I'm going to do is put a pencil mark there. So replace the rubber band with a pencil mark. Okay, this is treatment planning. What do I see? Patients missing posterior teeth, teeth above over erupted. Patient missing posterior teeth, tooth above over erupted. So straight away, from a treatment planning point of view, I'm thinking to myself, I'm thinking to Ivor, I'm looking at radiographs. Am I going to take those teeth out, replace by implants? Do I have a low sinus, in which case maybe I'm going to do a sinus graft and put implants in? Or am I going to do crown lengthening, root fillings, etc.? His teeth here already root filled, so I'm being pushed towards, let's do some crown lengthening, let's do some root filled, let's replace the root fillings or work with the cores so we can get these teeth looking a little bit further up. Next stage, I'm going to grind those upper teeth out of the way so I've got space to do my lower waxing. Now, hugely important piece of kit, okay? Boyle's plane analyzer. You get one of these from your lab technician. Mostly Crown and Bridge guys don't have them. These are denture prosthetic technicians. They have them. Okay. If you can't find one, email me. Okay. Our laboratory that I use in Sheffield, Gary Jenkinson at Art Laboratory in Sheffield. He makes them. He makes them for other laboratories, etc. So this is a Boyle's plane analyzer. What is it? It's a piece of plastic that's curved. And it's a piece of plastic that has the anatomical average curve of Wilson, anatomical average curve of Spey already in it. So what am I going to do? Remember, my technicians waxed up one tooth. I'm now going to take that Boyle's plane analyzer. I'm going to rest it on the superior third of my retromolar pads. I'm going to rest it on that one waxed up tooth. Okay. And now my technician is going to wax all of the undersurface, so all of the teeth, the lower teeth, to the undersurface of the Boyle's plane analyzer. Okay. And now my lower wax up has been completed. I've got my anatomical curve of Spey going through where it wants to at the back, where it should do at the back. It's an average curve of Spey, and my anterior reference point aesthetically is in exactly the right position. The curve of Spey, the average radius is between 4 to 4.5 inches. Again, depends on what study you use. But look, we've got a beautiful flattish, even occlusal plane. Flat occlusal planes, easy to disclude, shallow guidance. We protect our restorations, joint and muscles. Okay, next thing I'm going to do is I'm going to go to the top ones because my lower wax up completed. Okay, initially I'm doing a little bit of crown lengthening, asking my technician wax up to that level, not to this level, please. And then I'm going to go to the lip again, exactly the same idea. Probe behind the upper lip. So a 45-year-old, when he goes, Emma, how much upper tooth should he show? It's about 3/4 of a millimeter. So I'm going to go to the lip and I'm going to probe on upper right 1, find that the upper right central is 1 millimeter short of the lip. I'm going to add on 0.75. So Mr. Technician, please wax up upper central incisor 1.7 millimeters longer. Now wax up upper left central 1.7 millimeters longer. Now wax up the laterals so that they are about 1/4 to 1/2 inch shorter. Now wax up the canine so they're the same length as the centrals. Now I've got my central incisor occlusal plane. Next thing to do is to wax up the palatal aspects. So the palatal aspects come down and actually contact the lower incisors. So I've now waxed up the palatal aspects. Next stage, wax up the upper posteriors, lower posteriors down. This is the hardest part of the case, guys. This is it. The case has now been completed. Okay, it's been completed in wax. That's the hard part. The easy part is taking that with preparation guides, with prototypes, and it's now carpentry, taking that and putting it into the mouth. So our prototypes are exactly the same in the mouth, working on the prototypes and then changing and copying them in the definitives. But this is my end result. Okay, my case is completed. My full mouth diagnostic wax up is done at the correct vertical with the correct occlusal planes with my 5 principles of occlusion, and that gives me predictable end results. Okay, and here's my predictable end result. Here's my nice smile. Okay, he went for something like a B1, so there's a bit of color in there. If you remember from the original, he only had half a tooth gap there, so we decided to just go and cross that one over a little bit. And there's the final end result. Okay, and all we can see, and so this is my last clinical slide now. We're going to finish on this. I asked you the question, look at the difference between the two. Okay, and I was never going to be a male model. We know that. But what we've done, we've given him teeth back, number 1. So when he goes, Emma, he can see, everybody can see he's got teeth. Number 2, we've given him a nice smile. Okay, so this is a really, really nice smile. Right for his age, not too cosmetic, not ridiculously super white. Okay, but it's nice for his age. But also, look at the skin. Look at the skin pallor. Look at the eyes. look at the lower third of the face. He looks healthier. He looks better. He looks 5 years younger. Maybe you could squash it to 10 years. Okay. Does he look as though he's had a facelift? No. He looks as though he's been on holiday. He's lost some weight. He's been to a health farm. He just looks healthier. And that's my take-home message, guys. My take-home message is very much that if you can understand vertical dimension, if you can understand 5 principles of occlusion, then you can go and do beautiful full mouth reconstructions, partial reconstructions, make your patients so they have beautiful smiles, make them so they have younger appearances. But the huge point at the end of it is know your occlusion and you get predictable success rates. They work. It works, it works, it works, it works, it works. Nobody's going to tell you that we never have failures. But the whole point of doing this is minimize your failures, maximize your successes, helps you sleep at night. More patients want to come and get you to do the treatments because they look better, they last longer, they don't have people rushing back with temporaries coming off or with fractures of their veneers or crowns. So thank you very much for listening. Just a quick plug for Tipton Training and the British Academy, guys. We have been running webinars all throughout this lockdown period, completely, again, free of charge to the dental profession worldwide. Please go and visit www.tiptontraining.co.uk and you will be able to register free of charge for those webinars. If it's been of interest, then please contact me at Tipton Training or at Bard or my personal email, drpaultipton@gmail.com. And I'm here now to answer any further questions. So I hope you found that useful. I'm going to stop sharing and we can then hopefully come back to our previous screen. So let's go back and hopefully, there we go. Okay, over to you. That's my 2 hours done.
What an amazing lecture. My God. Thank you so much. We have learned so much from you here in this short period of time.
Thank you.
Just a couple of questions. How long do you temporize them for before you do your anterior guidance and then your posteriors?
I like to do it, if I can do, I like to take my time. Like you ask any prosthodontist, there's no rush, take your time. When we rush, things don't go right. So minimum time is 2 weeks, which is rushing. Maximum time is 3 months. After 3 months, my tissue is getting a bit soggy. So most of the time it's in between there, 4 to 6 weeks.
Have you ever had a scenario where you temporized them, you raised the vertical, and then they came back and explained that you have neck pain or side pain or something like that sort?
No.
No?
People ask, it's a great question to ask. So I don't want to be blasé about that. It's a great question because people say a lot of the time, do you test the vertical dimension, the new vertical? Do you test it first of all in any way? And the answer is, yes, we do. We test it for 2, 4, 6 weeks, etc. And I make sure that they're comfortable, that the occlusion side to side is easy. They're not complaining that they feel stressed, that they can talk and they like the looks. But basically, that is giving comfort to the patient. I am totally happy myself to go 2 weeks later and go and put the final restorations on. Okay. And the reason is that there's one caveat to that. The caveat is, does the patient have active TMD? If the patient has active TMD, we treat the TMD first of all, and then we do our reconstruction. Just like active occlusal disease, treat the occlusal disease, do the reconstruction. So we treat first of all. So if somebody has got active TMD, they're complaining of muscle pains, they've got clicking joints, they've got headaches, neck aches, then we'll go through occlusal splint therapy first of all. And that for me is the usual way. You know, I'm not going to say we get 100% success. No, 85%-ish. Some people need to go and have some surgery done. Some people need to wear the occlusal splint for up to 2 years. Depends on what their position has been before they're coming to see me for treatment, but usually we treat. I wouldn't dream of going to restorative work until we have the patients comfortable. So when we have the patient comfortable and the patient's been treated with an occlusal splint, remember what the occlusal splint does here. The occlusal splint is giving 5 principles of occlusion, which is what I've been talking about, and it's at an increased vertical dimension. Okay, think about the occlusal splint, typical Michigan splint. The way our technicians make Michigan splints is that mounted around RAP, then the occlusal pin is opened until the thinnest part of the splint is 2 millimeters over the retruded contact position. So if the retruded contact position is in a 6, for instance, my splint is 2 millimeters thick over the 6, which means it's 6 millimeters thick at the front, that 3-to-1. So now my patient's had the vertical dimension increased by 6 millimeters at the front on a piece of plastic with 5 principles. And guess what? All I'm going to do is transfer exactly that same thing to composite prototypes and then to my definitives. So if the question is, have I ever had somebody come back? Yes, I have. Okay. And the answer is, I've not done my job properly. I've made a mistake or missed a step out. So if I do my job properly, I'm comfortable my patients won't come back with those sorts of problems.
Excellent. What about headaches, Doc? Do you encounter a lot of that throughout the treatment to increase the vertical?
No, again, it's treat with occlusal splint therapy first of all. If you've got headaches, muscle aches, go and treat those first of all before we take a burr. Once the occlusal splint's done its job, okay, everything's working fine, then the next stage is usually occlusal adjustment. And I try to make sure that's not equilibration for me. That is occlusal adjustment. I get rid of the gross problems and allow the everything else to adapt. I'm not into fine tuning down to a micron here or a micron there. Get rid of the gross interferences. Then if my patient's still comfortable, I now go to restorations.
Wow. Excellent. Well, Dr. Tipton, this was an amazing lecture again, and we really are thankful for you taking the time and contributing to this project.
Thank you for the invitation and also for all the great work you're doing to get, I don't know how many it is, 50, 100, however many it is, dentists to come on and give free webinars at this stage is great. Thanks to you. We're doing them back in the UK. Not as many people are listening to us, but I know the amount of effort and work involved. And I've got 4 members of staff more or less just doing this all the time for no gain from ourselves. We're not getting anything from it whatsoever. All we're doing is I'm keeping my staff working so I can still pay them without having to lay them off. So I'm doing it for my staff, for the profession. You're doing it on a much bigger scale. I understand the amount of work involved. Thank you for doing that as well. Huge, huge plus for you.
Thank you. We all try to contribute in this peer-to-peer platform. It's a new concept, new idea. But know that the information that you have just revealed to our colleagues, there's tens of thousands of doctors that are going to benefit from it and be able to provide better care for their patients. So something to be very proud of. Thank you so much, Dr. Tipton. I wish you a wonderful Saturday. Take care.
Thank you very much indeed. Take care.